Neural tumors and mixed tumors. Neural and mixed tumors are a diverse group that includes tumors variously containing normal or abnormal neurons or normal or abnormal glial cells. Primitive neuroectodermal tumors arise from bipotential cells capable of differentiating into neurons or glial cells. Medulloblastoma. Medulloblastoma is classically described as the most common type of primitive neuroectodermal tumor, PNET, although this term has been removed in the latest WHO classification of central nervous system tumors. Most occur in the first decade of life, but there is a second peak around age 30. Medulloblastoma is the most common malignant pediatric brain tumor. They are usually midline. Most occur in the cerebellum and present with symptoms of increased ICP. Histologic characteristics include densely packed small round cells with large nuclei and scant cytoplasm. They are generally not encapsulated, frequently disseminate within the CNS, and should undergo surgical resection followed by radiation therapy and chemotherapy. Ganglioma. Ganglioma is a mixed tumor in which both neurons and glial cells are neoplastic. They occur in the first 3 decades of life, often in the medial temporal lobe, as circumscribed masses that may contain cysts or calcium and may enhance. The presenting symptom is usually a seizure due to the medial temporal location. Patients have a good prognosis after complete surgical resection. Neural crest tumors. Multipotent neural crest cells develop into a variety of disparate cell types, including smooth muscle cells, sympathetic and parasympathetic neurons, melanocytes, Schwann cells, and arachnoid cap cells. They migrate in early development from the primitive neural tube throughout the body. Miscellaneous tumors. Meningioma. Meningiomas are derived from arachnoid cap cells of the arachnoid mater. They appear to arise from the dura mater grossly and on MRI and are commonly referred to as dural-based tumors. The most common intracranial locations are along the Fowlkes figure 42-22, the convexities, i.e. over the cerebral hemispheres and the sphenoid wing. Less common locations include the foramen magnum, olfactory groove, and inside the lateral ventricle. Most are slow-growing, encapsulated benign tumors. Aggressive atypical or malignant meningiomas may invade adjacent bone or cerebral cortex. Aggressive atypical or malignant meningiomas may invade adjacent bone or cerebral cortex. Previous cranial irradiation increases the incidence of meningiomas. Approximately 10% of patients with a meningioma have multiple meningiomas. Total resection is curative, although involvement with small perforating arteries or cranial nerves may make total resection of skull-based tumors impossible without significant neurologic deficit. The Simpson grading scale is used to characterize the extent of resection. Small asymptomatic meningiomas can be followed until symptomatic or until significant growth is documented on serial imaging studies. Figure 42-22. Post-contrast T1 weighted coronal magnetic resonance imaging demonstrating a brightly enhancing lesion arising from the Fowlkes cerebri with moderate edema and mass effect on the right lateral ventricle. This is a Fowlkesian meningioma. Note also the small separate meningioma arising from the dura over the cerebral convexity. Atypical and malignant meningiomas may require postoperative radiation. Patients may develop recurrences from the surgical bed or distant de novo tumors. Vestibular schwannoma, acoustic neuroma. Vestibular schwannomas predominantly arise from the superior half of the vestibular portion of the vestibulocochlear nerve, cranial nerve 7th. Figure 42-23. Commonly, patients present with progressive hearing loss, tinnitus, or balance difficulty. Large tumors may cause brainstem compression and obstructive hydrocephalus. Bilateral acoustic neuromas are pathognomonic for neurofibromatosis type 2 NF2, a syndrome resulting from mutation of chromosome 22. NF2 patients have an increased incidence of spinal and cranial meningiomas and gliomas. Vestibular schwannomas may be treated with microsurgical resection, or SRS, gamma knife radiosurgery, or linear accelerator technology. The main complication with treatment is damage to the facial nerve, cranial nerve 7, which runs through the internal auditory canal with the vestibulocochlear nerve. Risk of facial nerve dysfunction increases with increasing tumor diameter. SRS is preferred for tumors less than 3 centimeters. And microsurgical resection for those greater than 3 centimeters, SRS, can be supplemented for any residual tumor following resection. Pituitary adenoma. Pituitary adenomas arise from the anterior pituitary gland adenohypophysis. Tumors less than 1 centimeter diameter are considered microadenomas. Larger tumors are macroadenomas. Meningioma at the top of the scan. Pituitary tumors may be functional, i.e. secrete endocrinologic. Pituitary tumors may be functional, i.e. secrete endocrinologically active compounds at pathologic levels, or non-functional, i.e. secrete nothing or inactive compounds. Functional tumors are often diagnosed when quite small due to endocrine dysfunction. The most common endocrine syndromes are Cushing's disease due to adrenocorticotropic hormone secretion, Forbes-Albright syndrome due to prolactin secretion, and acromegaly due to growth hormone secretion. Non-functional tumors are typically diagnosed as larger lesions, causing mass effects such as visual field deficits due to compression of the optic chiasm or panhypopituitarism due to compression of the gland. Figure 42-24 demonstrates a large pituitary adenoma. Hemorrhage into a pituitary tumor causes abrupt symptoms of headache, visual disturbance, decreased mental status, and endocrine dysfunction. This is known as pituitary apoplexy. Symptomatic pituitary tumors should be decompressed surgically to eliminate mass effect and/or to attempt an endocrine cure. However, prolactin-secreting tumors, prolactinomas, usually shrink with dopaminergic therapy alone. First-line pharmacotherapy for small prolactinomas is cabergoline, a dopamine agonist that inhibits production and secretion of prolactin and is preferred over bromocriptine for its superior side effect profile. Consider surgery for prolactinomas with persistent mass effect or endocrinologic dysfunction in spite of adequate dopamine agonist therapy. Most pituitary tumors are approached transnasally via the transsphenoidal approach, and minimally invasive endoscopic surgical techniques are being used increasingly. Hemangioblastoma. Hemangioblastomas occur almost exclusively in the posterior fossa, with about 20% occurring in patients with von Hippel-Lindau VHL disease, a multisystem neoplastic disorder. Other tumors associated with VHL are renal cell carcinoma, pheochromocytoma, and retinal angiomas. Many appear as cystic tumors with an enhancing tumor on the cyst wall known as the mural nodule. Surgical resection is curative for sporadic non-VHL associated tumors. Pathology reveals abundant thin-walled vascular channels. Internal debulking may be bloody, and block resection of the mural nodule alone, leaving the cyst wall, is sufficient. Lymphoma. CNS lymphoma may arise either primarily in the CNS or secondarily from systemic disease. Recent rising incidence may be due to growing transplant and AIDS populations. Presenting symptoms include mental status changes, headache due to increased ICP, and cranial nerve palsy due to lymphomatous meningitis, analogous to carcinomatous meningitis. Often, lymphoma appears hyperdense on CT due to dense cellularity. Most lesions typically enhance with contrast on MRI and can be differentiated by diffusion restriction on diffusion-weighted sequences. Surgical excision is not indicated. A stereotactic needle biopsy specimen usually confirms the diagnosis. Subsequent treatment includes steroids, whole brain radiation, and chemotherapy. Intrathecal methotrexate is an additional treatment option. Embryologic tumors. Embryologic tumors result from embryonal remnants that fail to involute completely or differentiate properly during development. Craniopharyngioma. Craniopharyngiomas are benign cystic lesions that occur in the sellar region that occur most frequently in children. A second peak of incidence also exists around 50 years of age. Craniopharyngiomas arise from remnant embryonic tissue in the pituitary stalk. Calcification occurs in all pediatric and roughly half of adult craniopharyngiomas. Symptoms result from compression of adjacent structures, especially the optic chiasm. Pituitary or hypothalamic dysfunction or hydrocephalus may develop. Treatment is primarily surgical excision. Figure 42-24. Post-contrast T1-weighted sagittal magnetic resonance imaging demonstrating a large sellar suprasellar lesion arrowhead is somewhat easier in children, as the tumor is often soft and easily suctioned. Adult tumors are often firm and adherent to adjacent vital structures. Visual loss, pituitary endocrine hypofunction, diabetes insipidus, and cognitive impairment from basal frontal injury are common complications. Epidermoid. Epidermoid tumors are cystic lesions with stratified squamous epithelial walls from trapped ectodermal cell rests that grow slowly and linearly by desquamation into the cyst cavity. The cysts contain keratin, cholesterol, and cellular debris, figure 42-25. They occur most frequently in the cerebellopontine angle and may cause symptoms due to brainstem compression. Recurrent bouts of aseptic meningitis may occur due to release of irritative cyst contents into the subarachnoid space. Malleritz meningitis. Treatment is surgical drainage and removal of the cyst wall. Intraoperative spillage of cyst contents may lead to severe chemical meningitis and must be avoided by containment and aspiration. Dermoids are less common than epidermoid tumors. They contain hair follicles and sebaceous glands in addition to a squamous epithelium. Dermoids may be found anywhere along the craniospinal axis. They are more commonly midline structures and are associated with more anomalies than epidermoids. They may be associated with trauma, as from a lumbar puncture that drags skin structures into the spine. Bacterial meningitis may occur when dermoids are associated with a dermal sinus tract. Treatment of symptomatic lesions is surgical resection, again with care to control cyst contents. Figure 42 to 25. Post-contrast T1 weighted axial magnetic teratoma. Teratomas are germ cell tumors that arise in the midline, often in the pineal region, the area behind the third ventricle above the midbrain and cerebellum. They contain elements from all three embryonal layers: ectoderm, mesoderm, and endoderm. Teratomas may contain skin, cartilage, GI glands, and teeth. Teratomas with more primitive features are more malignant, while those with more differentiated tissues are more benign. Surgical excision may be attempted. However, the prognosis for malignant teratomas is very poor. Spinal tumors. Approximately 20% of CNS tumors occur in the spine, and a wide variety of spinal tumors exist. Unlike cranial tumors, the majority of spinal tumors are histologically benign. Understanding two major spinal concepts, stability and neural compression, facilitates an understanding of the effects of spinal tumors. Destruction of bones or ligaments can cause spinal instability, leading to deformities such as compression, kyphosis, subluxation, all of which harbor the potential for subsequent neural compression. Tumor growth in the spinal canal or neural foramina can cause direct compression of the spinal cord or nerve roots and cause pain and loss of function. Classically, the pain is worse at night. Anatomic categorization provides the most logical approach to these tumors. Certain tumors present in characteristic locations. An understanding of the anatomy leads to an understanding of the clinical presentation and possible therapeutic options. Extradural tumors. Extradural tumors account for approximately 55% of spinal tumors. This category includes tumors arising within the bony vertebral structures and from within the epidural space. Destruction of the bone can lead to instability and fractures, causing pain and/or deformity. Epidural expansion can lead to spinal cord or nerve root compression, with myelopathy, radiculopathy, or a combination thereof. Metastatic tumors. Metastatic tumors are the most common extradural tumors. Spinal metastases most commonly occur in the thoracic and lumbar vertebral bodies because the greatest volume of red bone marrow is found in these regions. The most common primary sources of spine metastases are lymphoma, lung, breast, and prostate. Other sources include renal, colon, thyroid, sarcoma, and melanoma. Most spinal metastases create osteolytic lesions. Osteoblastic sclerotic lesions suggest prostate cancer in men and breast cancer in women. Patients with progressive neurologic dysfunction due to a metastatic lesion should undergo urgent surgery followed by radiation therapy. Patients with debilitating pain may undergo radiation therapy with close observation for neurologic deterioration. Preoperative neurologic function correlates with postoperative function. Patients may lose function over hours. These patients should be given high-dose IV dexamethasone, taken immediately to MRI, and then to the OR or radiation therapy suite. Indications for surgery include failure of radiation therapy, spinal instability, recurrence after radiation therapy, and the need for diagnosis in cases of unknown primary tumors. Most cases with significant bone involvement require both decompression and fusion. Bony fusion usually takes 2 to 3 months. Prognosis governs operative decisions. Surgery is unlikely to improve quality of life for patients with a life expectancy of 3 months or less, but it is likely to improve quality of life for patients with life expectancy of 6 months or more. Benefit for patients with 3 to 6 months life expectancy is unclear and requires frank discussion with the patient and family. Patients who are unlikely to tolerate general anesthesia, are already completely paralyzed, or who have very radiosensitive tumors such as multiple myeloma and lymphoma should not generally undergo surgery. Management principles of spinal cord compression and metastatic cancer of the spinal cord compression due to tumor burden is important to distinguish because it can, as with any other form of cord compression, cause paralysis and loss of bowel and bladder function. A randomized controlled trial demonstrated that patients with spinal cord compression from metastatic tumor have better outcomes with decompressive surgery and radiotherapy compared to radiotherapy alone. Patients with radiosensitive tumors, such as multiple myeloma and lymphoma, are excluded from this group. Another important tool in assessing these patients is the SINS Spinal Instability Neoplastic Score. This scale grades the utility of operative intervention in metastatic cancer to the spine on the basis of pain, deformity, location, type of bone lesion, integrity of vertebral body, and posterior element involvement. Primary tumors. Hemangiomas are benign tumors found in 10% of people at autopsy. They occur in the vertebral bodies of the thoracolumbar spine and are frequently asymptomatic. They are often vascular and may hemorrhage, causing pain or neurologic deficit. Large hemangiomas can destabilize the spine and predispose to fracture. Osteoblastic lesions include osteoid osteoma and osteoblastoma. The latter tends to be larger and more destructive. Aneurysmal bone cysts are non-neoplastic, expansal, lytic lesions containing thin-walled blood cavities. that usually occur in the lamina or spinous processes of the cervicothoracic spine. They may cause pain or sufficiently weaken the bone to cause a fracture. Cancers arising primarily in the bony spine include Ewing's sarcoma, osteosarcoma, chondrosarcoma, and plasmacytoma. Intradural extramedullary tumors constitute approximately 40% of spinal tumors and arise from the meninges or nerve root elements. They may compress the spinal cord, causing myelopathy, or the nerve roots, causing radiculopathy. The most common intradural extramedullary tumors are typically benign, slow-growing, and well-circumscribed. Rare benign epidural masses include arachnoid cysts, dermoids, and epidermoids. Rare malignant epidural tumors include metastases and high-grade gliomas or drop metastases from posterior fossa gliomas. Meningiomas arise from the arachnoidea mater. They appear to be dural-based and enhance on MRI. An enhancing dural tail may be seen. They occur most commonly in the thoracic spine, figure 4226, but also arise in the cervical and lumbar regions. Some spinal meningiomas grow into the figure 42 to 26 T2-weighted sagittal magnetic resonance imaging of the mid-thoracic spine, demonstrating a well-encapsulated tumor epidural space. Growth causes cord compression and progressive myelopathy with hyperaphlexia, spasticity, and gait difficulties. Surgical excision is the treatment of choice. The surgeon often finds a clean margin between the tumor, dura, and spinal cord, allowing en bloc resection without damage to the cord. Schwannomas are derived from peripheral nerve sheath Schwann cells. They are benign, encapsulated tumors that rarely undergo malignant degeneration. While 2/3 are entirely intradural, 1/6 are. The spine is a complex structure and is subject to an extensive array of pathologic processes, including degeneration, inflammation, infection, neoplasia, and trauma. Discussions of spine. The spine consists of a series of stacked vertebrae, intervening discs, and longitudinal ligaments. The vertebrae consist of the vertebral body anteriorly and the pedicles, articular facets, laminae, and spinous processes posteriorly. The intervertebral discs have two components. The tough fibrous ring that runs around the outer diameter of the two adjacent vertebral bodies is known as the annulus fibrosus. The spongy material inside the ring of the annulus is known as the nucleus pulposus. The annulus and nucleus provide a cushion between adjacent vertebral bodies, absorb forces transmitted to the spine, and allow some movement between the vertebral bodies. Stability. The spinal column is the principal structural component of the axial spine, and it must bear significant loads. The vertebrae increase in size from the top to the bottom of the spine, correlating with the increased total loads that the more caudal elements must bear. The cervical spine is the most mobile. Cervical stability depends greatly on the integrity of the ligaments that run from level to level. The thoracic spine is the least mobile due to the stabilizing effect of the rib cage. The lumbar spine has relatively massive vertebrae, supports heavy load, intermediate mobility. The sacral spine is fused together and has no intrinsic mobility. The load borne by the lumbar spine is transmitted to the sacrum and then the pelvis through the sacroiliac joints. The coccyx is the most inferior segment of the spine and has no significant contribution to load bearing or mobility. A stable spine is one that can bear normally experienced forces resulting from body mass movement and muscle contraction while maintaining normal structure and alignment. An unstable spine will shift or sublux under these forces. The determinants of spinal stability vary throughout the cervical, thoracic, and lumbar portions. In elementary form, stability depends on the structural integrity of the hard, bony elements of the vertebral column, as well as the tensile integrity and security of the supporting ligamentous attachments. Plain X-rays and CT scans are sensitive for detecting bony defects such as fractures or subluxation, while MRI better detects disruptions of the soft tissues, including ligaments and intervertebral discs. Specific patterns of abnormalities seen on imaging studies may suggest or diagnose spinal instability. A common form of non-traumatic spinal instability is lumbar spondylolisthesis, which is typically a forward slippage of a lumbar vertebra relative to the lower vertebra on which it rests. This results from congenital or degenerative disruption of the pars interarticularis, the critical bridge of bone that spans adjacent facet joints. In a setting of a pars defect, there is no solid bony connection between the adjacent vertebrae. The spine is unstable and anterior listhesis slippage may result. Patients typically present with severe low back pain that is exacerbated with movement and load-bearing mechanical low back pain. Radiculopathy in this setting indicates neuroforaminal compression. Figure 42 to 27 demonstrates an L4 and L5 spondylolisthesis. Figure 42 to 27. Lateral lumbar spine X-ray demonstrates a 25% anterior slippage of L4 neural compression. Besides providing a stable central element of the body's support structure, the The spine also protects the spinal cord and nerve roots as they pass through the neural foramina to form the peripheral nervous system. In a healthy spine, the spinal cord and nerve roots are suspended in CSF, free of mechanical compression. Pathologic processes that can lead to CSF space impingement and neural compression include hypertrophic degenerative changes in the intervertebral discs and facet joints, expansion of epidural masses such as tumors or abscesses, and subluxation, i.e. slippage, of adjacent vertebral bodies. Subluxation may be due to trauma that exceeds the spine's load-bearing capabilities and leads to structural failure or chronic structural degradation by degenerative disease, infection, or tumor. Subluxation reduces the cross-sectional area of the central canal and the neuroforamina. See Figure 4210b. Reduced central canal area can lead to myelopathy. Reduced neuroforaminal area can lead to radiculopathy. Myelopathy. Compression of the spinal cord can cause disturbance of function known as myelopathy. This dysfunction may be secondary to the direct effects of compression, cord ischemia due to reduced perfusion, or pathologic changes due to repeated cord trauma. These mechanisms lead to demyelination of the corticospinal tracts, which are long descending motor tracts. Corticospinal tract damage leads to upper motor neuron signs and symptoms, including hyperreflexia, spasticity, and weakness. These mechanisms also cause damage to the dorsal columns, which carry ascending proprioception, vibration, and two-point discrimination information. Loss of proprioception makes fine motor tasks and ambulation difficult. Radiculopathy. Compression of the nerve roots causes disturbance of root function, known as radiculopathy. Characteristic features of radiculopathy include lower motor neuron signs and symptoms, hyporeflexia, atrophy, and weakness, and sensory disturbances such as numbness or tingling sensations, paresthesias, burning sensations, dysesthesias, and shooting radicular pain. Myelopathy and radiculopathy often present together in diseases that involve the cervical radiculopathy. The cervical nerve roots exit the central canal above the pedicle of the same numbered vertebra and at the level of the higher adjacent intervertebral disc. For example, the C6 nerve root passes above the C6 pedicle at the level of the C5, C6 discs. The cervical nerve roots may be compressed acutely by disc herniation or chronically by hypertrophic degenerative changes of the discs, facets, and ligaments. Table 42-6 summarizes the effects of various disc herniations. Most patients with acute disc herniations will improve without surgery. NSAIDs or cervical traction may help alleviate symptoms. Patients whose symptoms do not resolve or who have significant weakness should undergo decompressive surgery. The two main options for nerve root decompression are anterior cervical discectomy and fusion, ACDF, and posterior cervical foraminotomy, keyhole foraminotomy. ACDF allows more direct access to and removal of the pathology anterior to the nerve root. However, the procedure requires fusion because discectomy causes a collapse of the inner body space and instability will likely occur. Figure 42-28 demonstrates a C6, C7 ACDF with the typical interposed graft and plating system. Keyhole foraminotomy allows for decompression without requiring Table 42-6 cervical bi-level fusion, but it is less effective for removing centrally located canal pathology. Cervical spondylotic myelopathy. The term spondylosis refers to diffuse degenerative and hypertrophic changes of the discs, intervertebral joints, and ligaments, which collectively result in spinal stenosis. Spinal cord dysfunction myelopathy due to cord compression from cervical spinal degenerative disease is therefore referred to as cervical spondylotic myelopathy, CSM. Classically, CSM presents with spasticity and hyperreflexia due to corticospinal tract dysfunction, upper extremity weakness, and atrophy from degeneration of the motor neurons in the anterior horns of the spinal gray matter, and loss of lower extremity proprioception due to dorsal column injury. Figure 42-29 demonstrates typical findings. Some patients complain of difficulty buttoning shirts, using utensils, and ambulating. Spondylosis is usually diffuse, so the usual treatment for CSM is multi-level, usually C3, C7, cervical laminectomy. Although patients with disease localized over 1 to 3 levels may be candidates for anterior decompression and fusion. Figure 42-30 demonstrates the postoperative appearance of a vertebral corpectomy and fusion for CSM. Thorough cervical laminectomy decompresses the cord posteriorly. Patients often have slow recovery due to the extensive chronic changes in the cervical cord and may benefit from rehabilitation programs. The other disease that classically presents with combined upper and lower motor neuron symptoms is amyotrophic lateral sclerosis, ALS. Care must be taken. Figure 42-29. T2 weighted sagittal to avoid offering cervical laminectomy to a patient with undiagnosed ALS. Two findings help differentiate CSM from ALS. Cranial nerve dysfunction such as dysphagia, not typically caused by cervical spine disease, and sensory disturbance not found in ALS. Thoracic disc herniation. Thoracic disc herniation accounts for less than 1% of herniated discs. A patient may present with radicular pain or sensoromotor changes in the lower extremities due to cord compression. A posterior approach via midline incision and laminectomy should be avoided because of the high incidence of cord injury from manipulation and retraction. Anterior approaches via thoracotomy minimize risk to the cord and allow excellent access to the disc. The radicular arteries running from the aorta to the thoracic cord should be spared when possible to avoid ischemia. Alternatively, a posterolateral approach is possible via resection of the rib head and facet joint. Finally, a transpedicular approach may be attempted for lateral disc herniations. Lumbar radiculopathy. Lumbar nerve roots exit the thecal sac, pass over the higher adjacent disc space, and exit the canal under the pedicle of the same numbered vertebra. Therefore, the L5 nerve root passes over the L405 disc space and exits under the L5 pedicle, figure 4231. Lumbar discs may herniate with or without a history of trauma or straining. Normally, they cause lancinating radicular pain down the leg, table 42-7. Most acute herniated lumbar discs improve symptomatically without surgery. Surgery is indicated for symptoms persisting more than 6 to 8 weeks, progressive motor deficit, e.g. foot drop, or for patients with incapacitating pain not manageable with analgesics. A recent randomized control trial spine, figure 42-30, lateral cervical. Patients' outcome research trial 74 did not observe significant differences between patients randomized to undergo surgery against conservative management when using an intento-treat analysis. Because of the high amount of bidirectional crossover between the surgery and conservative group, a subsequent reanalysis of the data as observational cohort analysis demonstrated improved functional outcomes in terms of pain and physical function, more so at 3 months than at 2 years. Discectomy is performed using a midline incision, partial removal of the overlying laminae, hemolaminectomy or laminotomy, identification of the thecal sac and nerve root, and extraction of disc fragments. Free-floating disc fragments may be found. Often, however, the herniated disc material is still contained within the annulus, requiring incision of the posterior longitudinal ligament and curettage of the disc space. After lumbar discectomy, approximately 2/3 of patients will have complete relief of pain, and up to 85% will have significant improvement. Neurogenic claudication. Neurogenic claudication is characterized by low back and leg pain that occurs while walking and is relieved by stopping, leaning forward, or sitting. It is normally caused by degenerative lumbar stenosis causing compression of the cauda equina. Neurogenic claudication must be distinguished from vascular claudication, which tends to resolve quickly with cessation of walking. There is typically no need to change position, and the pain follows a stocking distribution rather than a dermatomal distribution. Pallor and coldness of the feet and normal neurologic examination are also typical, though diabetic patients may present a challenge with microvascular. Neuropathy. Patients with neurogenic claudication have a slowly progressive course and may be surgical candidates when their pain interferes with their lifestyle. The usual surgery is an L3 to L5 lumbar laminectomy to decompress the nerve roots. A recent randomized control trial did not observe a significant difference in outcomes between surgical and conservative management of lumbar stenosis at 1 year. Thus, surgical management of lumbar stenosis should be reserved for patients that do not improve with physical therapy. Cauda equina syndrome. Cauda equina syndrome is due to compression of the cauda equina and may result from massive disc herniation, EDH, epidural abscess, tumor, or subluxation from trauma. Patients with cauda equina compression often present with urinary retention, saddle anesthesia, or progressing leg weakness. Saddle anesthesia is numbness in the perineum, genitals, buttocks, and upper inner thighs. Patients with suspected cauda equina syndrome should undergo immediate MRI of the lumbar spine to evaluate for a surgical lesion. Mass lesions should be removed urgently via laminectomy to preserve sphincter function and ambulation. Spine fusion surgery. Fusion surgery is often required for patients with spinal instability resulting from disease, surgical intervention, or both. Fusion. Table 42-7. Lumbar disc herniations and symptoms by level. Internal fixation devices for spinal segmental immobilization. Procedures lock adjacent vertebrae together. Fusion occurs when the body forms a solid mass of bone incorporating the adjacent vertebrae, eliminating normal intervertebral movement. Stabilization and immobilization promote bony fusion. Internal instrumentation and external orthoses are often used to stabilize and immobilize the fused spinal segments. Spinal instrumentation. Figure 42-32. A. Lateral lumbar spine. X-ray showing pedicle screws and connecting rods used to stabilize L4 with respect to L5. This instrumentation was placed as part of a fusion operation to stabilize progressive L4, L5 spondylolisthesis with intractable low back pain. B. Anteroposterior lumbar spine X-ray showing L3 to L5 instrumentation with pedicle screws and connecting rods. Arthrodesis refers to the obliteration of motion or instability by incorporating the relevant components into a solid mass of bone. Arthrodesis must occur in any fused segment to have long-term stability. Failure of arthrodesis results in failed fusion, often in the form of a fibrous non-union. The rates of successful fusion are higher in the cervical spine than the lumbar spine. Arthrodesis requires ingrowth of new bone formed by the patient's osteoblasts across the unstable defect. Inserting graft material such as autograft or allograft into the defect provides a bridge for osteoblasts and promotes fusion. The term autograft refers to the patient's own bone, often harvested from the iliac crest. Iliac crest bone graft is a source of both cortical and cancellous bone. Cortical bone provides structural support, while cancellous bone provides a matrix for bony ingrowth. The term allograft refers to sterilized bone from human tissue banks. Allografts also may be cortical, cancellous, or both. Allograft lacks the array of osteoinductive endogenous compounds intrinsic to autograft, although supplemental products such as demineralized bone matrix paste can be added to encourage new bone formation. Other techniques for increasing the rates of successful fusion are being developed, including the integration of osteoinductive bone morphogenetic proteins known as BMPs into the fusion constructs. Dynamic stabilization refers to the creation of spinal stability without achieving a bony fusion. The concept applies to both cervical and lumbar motion segments. Artificial lumbar and cervical disc replacement therapies are recent developments in degenerative spine disease that address this concept. However, their use is limited to very select cases. Another motion preservation technique that may hold promise is segmental soft stabilization. In cases of degenerative spondylolisthesis, such systems in the lumbar spine allow for decompressive laminectomy without increasing slippage. In theory, adjacent level facets and discs are spared the stresses of a neighboring bony fusion moment arm. Peripheral nerve. Common pathologic processes that compromise function of the peripheral nervous system include mechanical compression, ischemia, inflammation, and neoplasia. Peripheral nerve tumors. Most peripheral nerve tumors are benign and grow slowly. Significant pain increases the likelihood that the patient has a malignant tumor. Treatment for peripheral nerve tumors is surgical resection to establish diagnosis and evaluate for signs of malignancy. These tumors have various degrees of involvement with the parent nerve. Some can be resected with minimal or no damage to the nerve. Tumors that grow within the nerve often contain functioning fascicles. Total excision of these tumors requires sacrifice of the parent nerve. The choice of subtotal resection, nerve preservation, and observation against total resection with nerve sacrifice depends on tumor histology and the function of the parent nerve, schwannoma. Schwannomas are the most common peripheral nerve tumors, also referred to as neurilemomas or neurinomas. Most occur in the third decade of life. These benign tumors arise from Schwann cells, which form myelin in peripheral nerves. The most characteristic presentation is a mass lesion with point tenderness and shooting pains on direct palpation. Spontaneous or continuous pain suggests malignancy. Schwannomas tend to grow slowly and eccentrically on parent nerves. The eccentric location and discrete encapsulated nature of these tumors often allow total resection without significant damage to the parent nerve. Subtotal resection and observation is reasonable for schwannomas entwined in important nerves, as the incidence of malignant transformation is extremely low. Neurofibroma. Neurofibromas arise within the nerve and tend to be fusiform masses, unlike schwannomas, which tend to grow out of the nerve. Neurofibromas often present as a mass that is tender to palpation. They usually lack the shooting pains characteristic of schwannomas. Neurofibromas are often difficult to resect completely without sacrifice of the parent nerve. Neurofibromas have a higher incidence of malignant transformation. Therefore, patients with known residual tumors require close observation. Patients with